Hello, PMHMP students. You have all been doing so wonderfully with these case studies, and we just finished up week 3, so let's go ahead and review this case. So in this week's case study, we had Dan, a 38-year-old divorced male. He was presenting to the office with his ex-wife. Together they shared 2 teenage boys who said that Dad was staying up all night talking to himself loudly. They questioned why he wasn't sleeping, and he shared that he was deciphering clues found in the trash at work that he believes the FBI planted there for him. He thinks that he's been recruited by the FBI and that he is tasked with preventing the next terrorist attack. He reports he cannot give any more details on the information because it could put others in danger, and he's been calling into work for the past week so he can work on this assignment. In the interview, he's speaking rapidly, jumping from topic to topic. He reports that he stopped his brain medication a few months ago because he had been feeling well and didn't think he needed it anymore. His ex-wife does share that Dan was in a psych hospital for about 2 weeks 5 years ago, but had been doing well up until the past 2 weeks. He denies any SI or HI, denies delusions, hallucinations, feelings of persecution, preoccupation with religion, and no known drug use or abuse at present. So let's spend a little time talking about how we would assess this patient. You've all been doing such a great job and such a thorough job with your assessment questions for the case studies. So we've been differentiating between subjective and objective assessment questions. With your subjective, it's that patient account from themselves or their support individuals. They are the historians, and that's who you're gathering insight from. So that's where you're assessing for the chief complaint, and all of your questions will circulate around the time frame, any triggers, recent changes, how would they rate the quality or severity of those symptoms, inquire about modifying factors, how it's influencing their day-to-day function, and any sort of impact on interpersonal relationships, be it at home, socially, or at work. Then your psych review of symptoms is going to come into play after you assess for the chief complaint. So anything that hasn't already been ruled out through the information gathered for your chief complaint, you will inquire about here. And that will help you in your diagnostics later on. Then your safety assessments, questions circulating around past or current SI/HI, self-injurious behaviors. You're going to inquire about substance abuse, any illicit substance use, also nicotine, and don't forget to assess about caffeine intake. And then trauma, social and developmental questions, any pertinent family psychiatric history, also family medical history, right? Because you want to rule out any medical causes for these symptoms. And then there's a little bit of overlap as you're asking the patient about what medication he most recently stopped, right? Because that kind of falls into this elusive objective assessment, but it's still his account, right? And so can he remember what that medication was called, the dose, and the frequency of which he took it? And also assessing his compliance there with that medication across the years for which he took it. And then any other pertinent psychiatric history. So you want to ask questions about any past therapy, any other hospitalizations from his youth, teen years, early adult years, any rehab, any other trialed medications that were failed or stopped, and if so, why? And then you shift over into your objective assessment. And remember, objective assessments are all of your measurable data and your own perspective, right? So your own take of things. So it will be your observations coming into the mental status exam of their appearance, their behavior, their attitude, their speech, their affect, and then obviously their mood. It's going to be your questions that you pose in order to gather more information on their thought process, their thought content, and then the cognitive exam, which is still also measurable, right? And then your physical exam, height, weight, calculation of their BMI, vital signs gathered. And you have all been doing so great on the labs and the screening tools. So I have over here listed obviously labs, and the purpose of which being to rule out medical causes, right? And then also any substance use. So you can read through the list there of what all of your peers shared that was relevant. And then your screening tools, you did so amazing. You can see them all listed here as well. I won't run through saying them because it's going to be a tongue twister, but I was also very pleased to see that you guys mentioned the CSSRS since we were reviewing that this week specifically. I believe a few of you had also brought up the HCl32 and the BSDS. I did want to just share that's more, that's better for ruling out bipolar 2 disorder, not necessarily what we're seeing in this case study. So I wouldn't necessarily say that that should be something included, but I love seeing everyone's thought processes here. So it's good to bring it up because we can learn a little bit more about it. And then also imaging, many of you shared it would be wise to maybe get a CAT scan or an MRI and rule out any potential other causes, be it tumor or trauma that we are unaware of, right? Now you'll take all of that information that you gathered from your assessment so that you can make a diagnosis for your patient. And at times there's going to be that symptom overlap, and you'll be looking at different diagnostic criteria and potentials, different potentials that you'll be ruling out. So let's delve into some of the different ideas you all had on diagnoses for this patient, Dan. There's still not enough information to rule out substance use disorders, substance or medication-induced psychotic disorder, or a psychotic disorder due to another medical condition. We would have to wait for maybe labs to come back or imaging to come back or maybe some other information from our health assessment, right, in order to rule those out. So we'll step away from that at the moment and let's talk about some of the options you all brought up. For example, schizophrenia, some of you students suggested, but remember that we don't know for a 1 month period if he had this criteria A present yet. We also don't know if he had continuous signs persisting for at least 6 months, right, prior to our current information. And you can't have any manic episodes occurring concurrently with the active phase symptoms. So right now that would eliminate, right? Because he essentially is presenting with mania while also experiencing these delusions. And then some of you suggested delusional disorder, but we still don't know if he's had a duration of at least 1 month or longer of these delusions. And then others brought up brief psychotic disorder, but for that, it has to not be better explained by bipolar disorder or schizophrenia. So at the moment, we can't rule out bipolar disorder yet. And then other students suggested schizoaffective disorder, bipolar type. And for this, it's very similar to why we can't suggest or diagnose with schizophrenia right now, because we don't know if at any point during the lifetime of the illness, if criteria A was met for schizophrenia, and we don't know if delusions for Dan have been present for 2 or more weeks in the absence of a manic episode. So at the moment, that gets ruled out as well. So then we are guided towards bipolar disorders, right? What we do know from the case study is that Dan does have an abnormally elevated and expansive mood. We're unsure still about irritability in his mood, but he is persistently increased in his goal-directed activity. He has high energy, and we do know that it lasted at least 1 week, nearly every day. We know that we have 3 or more of the following symptoms present. The inflated grandiosity of his delusion, thinking that the FBI chose him for this task, right, and that he can stop the next terroristic attack. We know he has a decreased need for sleep. He's more talkative and has that pressure to keep talking from the information given in the case study. Most likely this flavor of a flight of ideas. We would probably get more about that in our assessment from the subjective experience, potentially the racing thoughts coming along with the task that he's sharing. We're unsure still about distractibility at the moment. And we're unsure about the psychomotor agitation. We would have to assess for that, but we do know he's got this increase in that goal-directed activity, honing in on this task. And then we would have to inquire further about whether or not there is a high potential for poor consequence with his involvement in this activity, right? Or if there's anything else that he's engaging in that would be of risk. And then we do know that the mood disturbance he's experiencing is causing a marked impairment in his social and occupational functioning, so between work and home life. And I do believe that it is necessitating hospitalization for Dan here so that we can get him maintained on medication again and treat these acute symptoms of mania and psychosis and hopefully prevent him from being a harm to himself. And we would have inquired also about any sort of potential harm to others. But I think that it is very safe to make the assumption that since he is a father of those teenage boys who at times are with him and not their mother, that there is a degree of risk there. So it would benefit his family as well for him to seek that treatment for stabilization. And then when we're talking about these psychotic features, so for Dan, it's specifically these grandiose delusions, right? And you want to identify whether it is mood congruent or mood incongruent. And so for him, he's having these delusions simultaneous to his manic presentation. And so it is mood congruent for Dan. And then at the moment, we cannot attribute it to a substance. So he meets all of this criteria for bipolar 1 mania with psychotic features. You all discussed very well-rounded treatment ideas for Dan, so let's jump into that now. In your peer discussions, there's been great conversation around a balanced approach to treatment, just making sure that you're including pharmacological and non-pharmacological measures. So that has been wonderful to see. And so for Dan, we absolutely know he's going to need medication management. We know we need to use antipsychotics to treat those symptoms of psychosis and his delusions. We know that we are going to need to stabilize his mood and treat those symptoms of mania. There may be associated anxiety that we would gather through our assessment, and so you could utilize in the acute phase medications like your hydroxyzine or even benzodiazepines, assess for substance use disorders obviously, and then you can differentiate between what would be best for him between long-acting, intermediate, or short-acting benzos, dependent on your setting as well, right? And then moving forward maintenance-wise, you could use buspirone. And then if the antipsychotics and mood stabilizers are not treating his sleep well enough, the symptoms of insomnia, you could bring on board trazodone, Remeron, doxepin. You could augment with those. And in terms of antipsychotics, we want you to gear towards, well, everybody should be gearing towards second generation atypicals because it carries a lower risk side effect profile, but don't shy away from your first generations, and many patients need those still. You just have to monitor for your EPS, your TD, and your neuroleptic malignant syndrome. If you're in an inpatient setting, that's a very controlled setting. You're monitoring them around the clock, so that's absolutely simple there. I shouldn't say simple, but it's a lot easier than when you're outpatient and you can't really monitor to the same degree those side effects. And moving forward, if compliance is an issue, consider your long-acting injectables. And for mood stabilizers, we'll talk about those options on the next slide. And then for non-pharmacological measures, remember that with chronic mental health conditions, psychotherapy as an adjunctive is huge. It helps improve med compliance and accountability. And then there's also the CBT psychosis specific. It's not going to eliminate his disorder, right? The brain chemistry there. However, it does help treat those associated symptoms. It changes his thought process and his approach and his coping strategies related to that, even in terms of like associated anxiety symptoms, for instance. And then building up a community around your patients, faith-based and community initiatives involving family and support individuals in their safety plan moving forward, and then Nutrition referrals are huge for patients who are going to be on medications like antipsychotics or mood stabilizers moving forward, just because of the impact it has on physical health. So if we can modify that lifestyle, approach, nutritional approach, then that can be huge to their health outcomes overall. Specific to Dan and really any patient, if you know what medication they were on previously and you know that it worked well for them, that is what you want to return to, be it a medication or a medication regimen, right? And so, like dual medications augmented together. But if you don't have that information, then you're going to have to decide on your own. So the symptoms will guide you, right? So we know that we want to treat his psychosis, his mania, and those insomnia symptoms. So in terms of antipsychotics, second generations, your Zyprexa, your Seroquel, or Risperdal would be best for that. Personally, I always kind of in this more acute phase go towards Zyprexa myself. It just becomes a style of prescribing for you, but I would do Zyprexa. Make sure that you utilize your baseline labs to guide you as well, right? And then obviously follow-up labs for your antipsychotics, EKG prior to initiating if you're able to get that done, and then your AIMS monitoring moving forward. And then for mood stabilization, treating those symptoms of mania, you could utilize Depakote or lithium. I would, moving forward maintenance-wise, maybe he used to be on Tegretol potentially, right? But that's not going to help you very acutely. It'll take a few weeks for you to kind of get him where he needs to be on the Tegretol. So really Depakote or lithium, within a few days or a week, you should be good. As long as you can, like for Depakote, get to that therapeutic dose. So plasma levels will guide you there for that. Make sure you get your baseline labs and your follow-up labs. And then for your lithium, obviously, you need an EKG if they're 40 to 50 or above, and then baseline labs, follow-up labs, and the trough level. Remember that in the acute phase, it's going to be a little bit, you want it to be a little bit higher, 1 to 1.5, but for chronic management, the gold standard is 0.6 to 1.2. And then you're going to augment with other agents as necessary, right? And what you treat a patient with acutely may not be what they stay on moving forward, right? But this would be ideal to Dan right now, hopefully trying to approach it with this sort of augmented adjunctive antipsychotic mood stabilization approach. And I was very excited to see that some of you discussed the LEAP approach here as well, right? So I just wanted to tie that in as well. Let's go ahead and go to our next slide. Oh, look, I said let's go to the next slide, but it's just our references. So we will stop here, and I'm so excited with the level of engagement we've been seeing in these case study discussion boards, and I hope that it has been very complementary to your clinical experiences right now, and that it is helping to strengthen your comfort level in terms of analyzing different presentations and formulating treatment plans moving forward, or thinking through the process overall. And if you guys ever have any questions, feel free to reach out to your instructors, okay? Great job, everyone.